So this webinar is designed to bring together public health experts to discuss workforce issues in the region. How should the public health workforce be defined? What are the public health workforce needs in the Pacific? Is the current workforce meeting this demand? And how does the public health workforce fit into the public health workforce globally? So I'd like to start by introducing the first panellist to speak, who is Vivian Lin. She has more than 35 years international experience in public health and health policy, with a variety of roles in policy and program development, health services planning, research and teaching. She's currently Director of Health Systems Division at the Western Pacific Regional Office of the World Health Organization, where she has responsibility for universal health coverage and sustainable development goals. On leave from her role as Professor of Public Health at La Trobe University in Melbourne, Australia, she's author of several leading textbooks in Australia, as well as on China, and remains a member of the International Panel on Social Progress. Vivian's worked at senior levels in health policy in several Australian jurisdictions, with responsibility for a wide range of health policy and program areas. She's also consulted widely for the World Bank, UK Department for International Development, AusAid, as well as the World Health Organization. She's served on numerous academic, professional, government and community boards in relation to health promotion, public health education and research, public health and health workforce regulation, women's health, Aboriginal health, Chinese community and Australia-China relations. She's also served on multiple editorial boards for leading journals, including Social Science and Medicine. Thank you very much for being here, Vivian.
Thank you very much. It's a great pleasure to be part of this conversation, and a very important one at that. Let me perhaps just give a brief overview of some of the issues as we see them in the Western Pacific region. And it's really great to see the PHAA coordinating this effort, because I think there are many issues we do need to address. Perhaps let me start out by more of an apology for what the WHO is really not doing very much about. And that is, while we do have a global strategy for health workforce, and many countries are in various processes about looking at the health workforce, unfortunately, the tendency is to think about just the doctors and the nurses. To some extent in primary care, quite a lot of time in the hospital. You know, how many surgeons we need, and how many midwives we need. That tends to be the orientation. And globally, there's, of course, been a lot of concern about the migration of the health workforce, and countries have agreed to a code of conduct and to report every other year. The WHO has also provided specific tools for workforce planning, whether that is looking at the workload and therefore how do you calculate the workforce required, or looking more broadly at the health labor market and the way people come in and out of a workforce as a tool for workforce planning. All of which, as I say, tends to focus on doctors and nurses, without necessarily thinking about what services they are going to provide. And of course, in a lot of our countries, it's not just the services, but it's also very basic things like education, regulation, registration, and in many countries, the need to transform the education to address the demographic and epidemiological challenges at the moment. So I think, so by the way, as I say, of an apology, I think the public health workforce does not occupy a very strong place at the global level for consideration, other than more recently in the context of Ebola and the joint external evaluation, or the JEE processes that have happened, where there has been a great concern about the workforce. And that's a workforce very much focused on field epidemiology. And we now have undertaken quite a number of JEEs in our region, and we can see that in many countries, when they think about health workforce planning, the number of field epidemiology people is not part of the overall workforce plan. We do have institutions that do the 1-year training, but it hasn't been necessarily thought about more broadly in terms of totality. Of course, that raises, therefore, the question of what is a public health workforce? And I think it's quite easy to identify, basic expertise that needs to be in a system, such as epidemiology, such as environmental health. Occupational health remains very important in many of our countries where there's rapid economic development. Health promotion, community development, health communications is an increasingly important workforce that I don't think we are as systematic in the way we approach it. And so if we start to think about the challenges of the Pacific, such as the NCD crisis, of course, we need the infectious disease and the health emergencies orientation, but we do need much more with the health promotional workforce and people who can reorient the nature of clinical services to a more preventive and population-wide approach. It also means that we need to start to think about a public health trained workforce that are perhaps working in health policy, in health law, because so many of the interventions we need are actually at that level, just as when we don't have the luxury in smaller countries of having a lot of specialization. And in an era where countries are committed to universal health coverage with primary health care as the foundation and recognizing the need to strengthen that, then what is the public health knowledge and skill base that must be there in that primary healthcare workforce, in that clinical workforce? So I think these are some of the issues that we do need to start to look at, whether it's on-the-job training or whether it is making sure that we have qualifications. We do see across the Pacific that we do have a range of different programs, whether that's a public health officer at the bachelor level or master of public health or field epidemiology or postgraduate in primary healthcare. So these are a variety of opportunities. But certainly I think across the board, the region, the picture is very mixed, and Australia and New Zealand do have the probably the best developed models and the most systematic approach, comparatively speaking. But it's also, these are high income countries, and we do need to think about what is the best way that we can support the issues in the Pacific. So I think those are some brief opening comments from me, and I hope that gives everyone a bit of a picture of some of the issues. Thank you.
Thank you very much, Vivian. That was a really good introduction to some of the bigger picture issues that we're facing. We've just been joined by Paula Vivilli and Berlin Kafoa from the Pacific community, just in time because you are up as our next speakers. The Pacific community is the principal scientific and technical organisation in the Pacific region, proudly supporting development since 1947. It's an international development organisation owned and governed by its 26 country and territory members. SPC is also the Secretariat for the Pacific Public Health Association. Dr. Paula Vivilli is the Director of Public Health for the Pacific community based in Noumea and New Caledonia. Prior to joining SPC, he worked for the Ministry of Health in the Kingdom of Tonga for about 20 years. His area of primary expertise is non-communicable diseases, but has also been involved with initiatives on health systems strengthening. He also provides counsel for various regional research and advisory groups, currently serving on the New Zealand Health Research Council's Pacific Health Research Committee, the Fijian National University's Centre for the Prevention of Obesity and Non-Communicable Diseases Reference Group, and the University of Otago's Pacific Reference Group, as well as the Commonwealth Advisory Committee on Health. Dr. Berlin Kathoa is currently team leader of the Clinical Services Program at the Public Health Division of the Pacific Community. Dr. Kathoa is a medical graduate who has a master's from UNSW, Sydney, and a fellowship in public health from the Royal College of Physicians in the UK. He's also a registered general practitioner and a specialist public health physician in Fiji. Prior to joining SPC, he was Associate Dean at the Fiji School of Medicine. Thank you very much for joining us, Paula and Berlin.
Thank you very much for having us, and we're very happy to be part of the webinar today. Can we just convey Colin's apologies again? Many of you know that Colin was actually supposed to be the person talking to you people, but unfortunately his flights were changed, and so he's currently flying. We'll just give you some brief issues after discussing some of the issues related to public health, human resource in the Pacific. And briefly, we're going to talk about four main areas. One is the lack of information, which Vivian has alluded to. The second one is just some anecdotal evidence on numbers. The third one is on training. And the fourth one will be on accreditation, career pathway issues. Just to reiterate the point that Vivian has given, and that is the lack of information. We also house the clinical services program here at SPC, and we work very closely with and other partners. We have pretty good information on clinical staff and that work in the region. And for example, we could give you numbers of doctors in each discipline in clinical medicine, and we have some information on nurses as well. But for public health, we have, at this point in time anyway, no information. And as Vivian discussed, some of this is linked to the different definitions in the countries. It's one definition does not necessarily mean the same for the other. For example, in Fiji, the hospitals in the outer islands are actually classed as public health. And so although they're clinicians, they're classed under public health. And so we have a bit of difficulty. If you're looking to register an epidemiologist, for example, by and large, the registration councils don't have a definition for that, whereas they will have a definition for pediatrician and physician and all the rest of it. So there are issues around definitions and consistency that obviously is a challenge. And this is an area that we are looking into doing some work in ourselves. On numbers, if we're looking at the different cadres in general, medical doctors by and large is lacking. And for example, in many countries, public health doctors who are trained in public health with mostly masters in public health would normally number in the same numbers as you would for one division in a hospital. So public health doctors would equal number of clinicians in pediatrics, for example, in a country. And so not very many. If we're looking at environmental health officers, we have training for these in many of the countries. And so the numbers for these perhaps could be termed adequate. Nurses are limited in numbers, for others, a little bit more in others. But so by and large, if you're looking at the different cadres, there are some gaps in others, and others a little bit better served. For training, undergraduate training is mostly available at universities. Fiji National University and USP is starting a new course on Bachelor's Public Health, and Diploma in Public Health is also available. One of the things that we do with WHO and our colleagues from up north from Pihoa is a postgraduate certificate in field epidemiology, which we teach in country. And it's made up of 5 modules and is accredited and awarded by FNU, Fiji National University. And we are looking into progressing from the postgraduate certificate level to a postgraduate diploma next year. And FNU is also working with us on a master's design program, which incorporates our course plus their master's in applied epi. Briefly, we'll just, and of course, Vivian knows that Colin does some courses for training through the principal on their Colin network. Finally, very briefly, before we finish off our intervention for now, is on career pathway. This is actually one of the challenges for public health people. If you look at doctors, for example, Public health doctors don't have a professional mechanism where they can become members of colleges within the region after they do their postgraduate training. Some of the public health people have become members of New Zealand College. Others have become members of the UK college. In terms of it would be a good pathway for Pacific Islanders.
You are fading, Paula. We can't hear you well.
Is that a bit better?
Yes, better.
Yeah. So perhaps I'll just leave it there, and I can talk about nurses and others later. But just to say that career pathway, postmasters, and accreditation is a challenge that we can discuss further. And I'll leave it there for now, Ingrid.
Thank you very much. And now we'll move on to Gerhard Sunborn from New Zealand. He's a public health physician and deputy chair of Moana Ola, the Pacifica Public Health Network in New Zealand, which provides an independent, inclusive and collective Pacifica public health voice regarding health, social and economic issues impacting Pacifica families and communities in New Zealand. Dr. Sunborn is also the founder of Fizz, Fighting Sugar in Soft Drinks, and is also known as Dr. Fizz. Thank you very much for joining us today.
Thank you. I'm not a public health physician. I've done a PhD in community health and public health with the University of Auckland. Thanks very much for having me today. And yeah, so I'd just like to declare that I know there's a lot of important issues and areas around what we're talking about today, but kind of the area that I focus my attention on over the past 5 to 10 years has been around NCDs and particularly over the last 5 or 6 years around sugar and sugary drinks and their contribution to NCDs and a few other things. A little bit about my journey. Initially, I looked at why our Pacific community didn't receive much surgery for heart disease, in spite of having very high prevalence compared to other New Zealanders. My PhD looked at kind of moderators, looking at different levels of glucose in bloods and lipids and blood pressure and those types of things. And now my journey has pushed me more towards prevention and focusing particularly on sugar and sugary drinks. And so I think over my journey, and what I think is important here is that we need to focus on things that we think are important in public health. And I think historically sugar and sugary drinks being the largest contributor of sugar to many people's diets and children has been overlooked. So the work I've done has focused primarily on sugar and sugary drinks. And, I understand that, the social determinants are a major and huge contributor to unhealth and poor health and that type of stuff. But I think, to focus on something that we are able to do something about, I think is really, really useful. And I just want to talk a little bit about one story in particular. There's a school here in Auckland, and it's in a very high deprivation area. And when a new principal came into the school, there were a number of different issues, behaviour, health and absenteeism and achievement and things like that. But the first thing that she thought she'd do is introduce a water-only policy. And overnight, behaviour changed and a number of other things changed. But there was a paper that we looked at around looking at the data on dental caries, and we found that these children, compared to the 8 surrounding primary schools, had 1 fewer disease missing or filled tooth compared for every 2 of their children compared to the 8 surrounding schools. And so although their policy around water was brought in because the behavioural issues, unexpected consequence was around dental caries. And so I've looked at a few other papers that have tried to address dental caries in the Pacific and elsewhere through general health promotion strategies, which are focused on dental hygiene, brushing, flossing, using fluoridation and things like that. And the few papers that I have found that there was no difference in those groups when they had a comparison group and an intervention group through doing that oral hygiene. So, but when we look at this school in particular, who had a water-only policy, they had significantly better teeth. So I think kind of thinking about, for one issue like oral health, by teaching dental hygiene, it isn't as effective as looking at something like sugar in the diets of children. So I think that's one issue, but we know there's a lot of strong evidence that shows that sugar intake and sugary drink intake is an independent risk factor for a raft of other issues and non-communicable diseases like type 2 diabetes, cardiovascular disease, heart disease, gout, on top of all the other issues around behaviour and concentration. So I think having a focus, and for the work I do, it's around sugary drinks, and sugar, I think it's important for us in public health and in the region to focus on things that we think can cause change. And I know there's a lot of, I'm not hugely familiar with everything that's going on in the Pacific region. I know Paula and your team would be more familiar with that. I know there are quite hefty sugary drink taxes in some countries. But I think, yeah, those are the things that I think are useful. And I think, focusing our efforts, particularly around non-communicable diseases, for those types of things, I think there needs to be a stronger focus on sugar and its role in causing those high rates of disease. Another issue that me and a few of my colleagues have been looking at lately, which is an infectious disease, is around scabies. And I think scabies has also been kind of historically overlooked. And here in New Zealand, with our Māori and Pacifica communities, we have huge rates of rheumatic heart disease. And in other regions, like I think in Indigenous, Aboriginal in Australia and other parts of Trinidad and Tobago, there's been a strong link shown between scabies and acute rheumatic fever. And in a recent paper that my colleague led, we found a hazard ratio of about 27, linking scabies to acute rheumatic fever here in New Zealand. And to put that in perspective, the hazard ratio between tobacco and cancer is about 9. And so the hazard ratio of 27 is about 3 times that. So we think that another kind of area that could be useful to focus on in prevention of a lot of diseases and illnesses such as impetigo, cellulitis, skin infections, and possibly, if the link is established, rheumatic heart disease, that addressing historically overlooked illness like scabies would be really useful as well. So that's kind of something, an area that is new that we're looking at, and we know that there's a few prevalent studies done in the Pacific region, and I think there has been high rates of scabies, but again, it's something that hasn't been looked at very well lately. And I think the last prevalent study of scabies here in New Zealand was back in 1970. So that's another area that we're kind of looking at. And so, yeah, I think that when it comes to the workforce, I think focusing our probably quite small public health workforce that exists in the Pacific region on things that we think are important and we can make, by addressing them, create strong beneficial outcomes, I think is important. And maybe to providing what you were talking about here, a network where we can share ideas and findings that may be applicable to the Pacific region from here in New Zealand as well as Australia to the wider Pacific region, I think is important and valuable. So yeah, thank you.
Thank you very much, Gerhard. That's a very good reminder talking about sugar. There are lots of issues, clearly, for public health and the public health workforce in the Pacific, but it's a great reminder that there's also things that they can definitely do right. We are spinning around in circles in Australia trying to get a sugar tax, and in the Pacific, you just went out and did it. If we can move on now to Warren Lindbergh and Sione Tuitahi. Warren took up his current position as the Chief Executive Officer for the Public Health Association in New Zealand in September 2012, following 6 years as Group Manager for Public Health Operations in the Ministry of Health. Although he began his working life as a teacher in South Auckland, he's best known as the first Executive Director of the New Zealand AIDS Foundation from 1986 to 1998. Over the last 20 years, he's also worked on a wide range of other public health issues, including the Like Minds, Like Mine media campaign to counter stigma and discrimination associated with mental illness, and the Auckland Regional Migrant and Refugee Settlement Strategy. He was also the Human Rights Commissioner from 2001 to 2007, and last visited the Pacific as a member of the UN AIDS Commission on AIDS in the Pacific in 2008. In 1999, he was made a member of the New Zealand Order of Merit for Services to Welfare. Sione Tuitahi is the Executive Director of the Health Promotion Forum of New Zealand. And Sione, you can rescue me here or laugh as you see fit. Ruananga Wakapiki Aki Ite Haoa O Aotearoa.
Very good for a first time.
Thank you. An educator, author, and health promotion professional, his areas of interest include health promotion, determinants of health, human rights, community development, public policy, and workforce development. Sione is the current Vice President of the International Union for Health Promotion and Education for the Southwest Pacific region and a member of their Global Executive Board. The International Union is an umbrella organisation for health promotional professionals and institutions throughout the world. Sione joined the Health Promotion Forum of New Zealand in 2005 after 6 years as Pacific Manager at the Auckland Regional Public Health Service. He's also taught at a number of tertiary educational institutions. For more than 10 years, he led the building of Pacific capacity at Massey University. A former journalist and broadcaster, Sione is the author of a number of books, academic papers, and children's stories. As a voluntary community worker, he's a member of several national advisory groups in health, education, and community sectors. And I should say, I noticed that we had a couple of questions come in, which is fantastic. If you use the Q&A function to write questions, we will save them until after each of the panelists has spoken, and then we will have a discussion time where we will address those questions. So thank you very much. Over to Warren and Sione.
You go first, Warren.
Thanks, Ingrid. Kia ora tātou from New Zealand. I think that the intention of this exercise is really important. That there are such a lot of connections between New Zealand and the Pacific. I mean, Gerhard and Sione demonstrate that. But I do think we can do better. I was there the day that Colin Tokutonga launched the Pacific Public Health Association. In fact, I think I was a founding member. But I think that we haven't really explored the potential for closer working together along the lines of the sort of things that Gerhard was talking about. But we have existing ties. I think it's more a matter of realizing their potential. We are in a very changing environment. We're in a changing political environment, which I think is going to be beneficial for public health. We have a government that's determined to look at the social and economic determinants. They are not yet looking at public health because they've inherited some huge problems with the health, that part of the health system, which in fact has been privileged over the last decade. But just focusing on doctors and nurses and hospitals doesn't solve the bigger problems. And those are the things where I think Gerhard gave some good examples of getting down to where people live, work, and play, and how can we build the potential for us to work collaboratively in these areas. So my only contribution to this really is to say that I think it's a good idea, that it will be, there's some challenges involved, especially financial ones, but then we've also got a Minister of Foreign Affairs who thinks the Pacific should be prioritised, so we should be knocking on his door. And I think that there'll be a lot of uncertainty, and learning to live with uncertainty is one of the skills that we're going to have to teach our students much more effectively than we do. But I'd really like to let Sione have the opportunity to say a few words.
Thank you, Warren, and warm Pacific greetings from Auckland to all colleagues around the region. Along with Warren, we are privileged to have this opportunity to share some of our thoughts with you. And perhaps, Ingrid, I'll check at this point whether you can hear me loud and clear enough.
Yeah, that's perfect.
Okay, great. As Warren mentioned, here in New Zealand, we have enough adequate resources and infrastructures enough to teach public health and to research public health issues and to be able to provide the ongoing professional development for the public health workforce. And some examples of that are the ministry is leading in making sure that public health is still a significant component of the makeup of the ministry. Although in the big scheme of things, as you know, it's a world, pattern that the clinical health is always the top of the list, and public health is often, if not always, the poor cousin. And within that, health promotion, which I represent in the context of this conversation, is the poorer cousin, of those two poor cousins. But I'll talk to that a little bit more. We, as Warren said, it's a changing political environment and socio-economic environment in New Zealand. We have a government that is now supporting the redevelopment of public health and building its capacity. We have most of the universities that teach health and medicine. There are strong public health units and divisions within those universities. Auckland University, Otago University, Massey University, Victoria University, of course, they lead, as well as the two Maori tertiary institutions. They both have health components, divisions, and within those units, they have public health units. And so are the polytechs in New Zealand and some of the private establishments, entities in New Zealand. In short, the training of public health capacity, training of the workforce is well set up, but there are, of course, ongoing challenges in terms of resources, funding, and so on and so forth. We are vulnerable to the political cycle. as we have mentioned already, when the government of the day comes in with with support for public health, and we see resources allocated accordingly. When that political environment changes, public health suffers. The curriculum for public health has been well developed, not only in the tertiary educational institutions, but also for the curriculum, the national curriculum for New Zealand, the New Zealand Qualifications Authority. Warren and I and others have worked towards that to make sure that there are public health qualifications. And within that, qualifications that address the training needs of the Pacific workforce here in New Zealand. There are also professional bodies, as Warren mentioned. There is the Pacific Public Health Association located in the Pacific, but there are members, and there's a branch here in New Zealand. Warren, of course, represents the Public Health Association, and I represent the Health Promotion Forum of New Zealand that covers the two broad areas, public health, health promotion. One of our colleagues, Pam Watson, she's the CEO. She's not party to this conversation. She is the CEO of the College of Public Health Medicine. And Moana Aula, as mentioned by Gerhard, was established a few years back to focus, along with the Pacifica Medical Association, on the needs of Pacific peoples, the professional development, building the workforce capacity of the public health workforce. There are some individual programs that are between organizations and the Pacific countries that are in existence already. But I think it's a good idea to continue to explore those relationships. And with the current environment, foreign affairs keen to make New Zealand's presence in terms of contribution to the socio-economic development of the region, those are avenues to be further explored. And of course, more formal links with some of the public health units in the tertiary educational institutions in the Pacific, as mentioned by Paula, the Fiji National University and the University of the South Pacific. The Health Promotion Forum has a work relationship with SPC, along with other regional development partners in the Pacific. I'll touch on something that Vivian mentioned before, the emphasis on the clinical workforce, doctors and nurses, and therefore the unregulated workforce, health promotion and allied workforce, to a smaller degree, not the attention on developing their capacity is not to the same degree as we look after the clinical, our clinical and medical colleagues. However, on the global level, and as mentioned earlier by Ingrid in the introduction of Warren and me, I am a member of the Global Executive Board of the Health Promotion of the Union for Health Promotion and Education, IUHPE. And IUHPE has launched a global accreditation framework for health promotion. The Australian Health Promotion Association is now a member and is now a national accreditation organization. Here in New Zealand, the Health Promotion Forum is leading the development for New Zealand. And in a year or two time, we will become a national accreditation organization. And therefore, health promotion as a professional practice or as a discipline will become more formalized. And there will be a register, although not regulated. But those are some steps towards recognizing, formalizing the specialized area of health promotion in the broader, public health competencies. To that end, we are also hosting a world conference here in New Zealand next year with the International Union for Health Promotion and Education, and Paula and Berlin and Colin and their team SPC are party to that, as well as the Australian Health Promotion Association, and of course, Warren and his team here in New Zealand. And Moanaula is part of that. And it's an event, but it's part of a process of advancing the workforce capacity of public health, although focusing on health promotion in this case. Yeah, those are some of the developments here in New Zealand and the region and the world, especially health promotion that we are party to here at the Health Promotion Forum. But going back to the Pacific workforce here in New Zealand and the ongoing development of their capacity, Warren and I are members of a reference group that is working on the national workforce development strategy for public health here in New Zealand. Our next meeting is tomorrow, and one of the areas of our focus is actually the Pacific public health workforce capacity. And it is an indication that at the national level here in New Zealand, we prioritize the workforce development needs of our Pacific colleagues here in New Zealand, and to some small degree, because of the mobility of the workforce between the Pacific and New Zealand and Australia, for that matter, of course, and other metropolitan centers, we prioritize that in our national workforce development work. And Moanaula was established, as I mentioned earlier, to ensure that there's focus and there's equal attention to building the needs of the Pacific workforce here in New Zealand, especially public health. And it's because of the high needs of the Pacific communities in New Zealand, as well as opportunities for the Pacific workforce to contribute to national health challenges that we all face here in New Zealand. I'd like to round up my comments at this stage with the changing nature of what needs to be taught in public health. As you know, all health challenges are now global, but they impact on the national and the local. And environmental determinants of health and well-being is one of those global issues that we need to consider now when we design public health qualifications and all of that. Again, the conference in health promotion here, April next year here in New Zealand, will have a look at that, especially at the determinants of health level, and especially linking that with the framework of the SDGs, as the WHO has did in November 2016, asking the question, what is the role of health promotion in the Sustainable Development Goals of the UN, that most countries sign up to. So I would like to pause there, and Ingrid, thank you very much for the opportunity.
Thank you very much, Warren and Fiona. It's good reminders of several different things, how important the political context is and the global issues like the SDGs. And it's good to hear about some of the local initiatives that are going on. Our final speaker is Ian Lee. He's an economist based at the School of Population and Global Health at the University of Western Australia. He teaches health economics and policy in the population health undergraduate major, as well as the Master of Public Health programs. Ian has research interests in health and labour economics, and he's particularly interested in issues relating to cost effectiveness in the health system, building a healthy health workforce, Australian higher education policy, and how childhood issues and interventions can influence outcomes over the life cycle. Thanks very much, Ian.
Thanks for the introduction, Ingrid, and very pleased to be here today. I guess in terms of thinking about the various questions that were posed as the focus of today's webinar, it just struck me how much we do not actually know. So perhaps the first major point that I have to make is that the public health workforce is really challenging to define. There is more than one definition in use. Various bodies and organizations use very different definitions, and the definitions range from being really broad to the point of being all inclusive, to on the other end of the spectrum being really, really specific. And there are a lot of different approaches to defining the public health workforce. And at the same time, as a couple of panelists have already mentioned before me, there is a lack of research into the public health workforce. The national studies of the health workforce tend to focus on issues related to either the medical workforce or the nursing workforce, with all other aspects of the health workforce being aggregated into miscellaneous and all other category. And again, the lack of a proper definition for the public health workforce has not really facilitated the research into the public health workforce. And I think that we have to acknowledge that coming to a consensus on what the public health workforce is going to be tricky. Core functions of a public health worker is quite broad, quite diverse, and quite complex. So someone working in public health might do research, look at health issues and hazards in the community, develop and plan health policy, conduct workforce planning, even and there's a lot of different functions that someone in the public health workforce would do. And underlying that diversity, again, is a diversity of backgrounds. Individuals working in public health can come from a variety of different qualifications, fields, and all walks of life. So while there are degrees with a public health focus, lots of people working in public health would actually hold qualification in other health fields and also non-health fields, and that's reflective of the scope of what we do in public health, as well as how the improvement of well-being is multifaceted and interdisciplinary. But that really makes planning and developing a public health workforce quite tricky as well. There is an imbalance in the capacity of the health workforce. So I think a few other panelists have also mentioned before me that we have a lot of statistics on the number of doctors, for example, for a given number of population across countries. And so we can look at whether there's a scarcity or surplus of the medical workforce in countries and even in regions. But we don't have same or similar statistics of the public health workforce across the region. And finding that out is quite essential and potentially valuable, as public health initiatives can be very cost effective. Knowing more about the public health workforce is also essential, because workforce development takes a really long time and needs to be very forward-looking, and short-term fixes to any to any workforce issue is sometimes not possible, or it can be suboptimal. And in Australia, we know that broadly speaking, for the entire health workforce, we have an aging health workforce. And so training up a replacement health workforce has been a priority area. But for the public health workforce, again, we have very little sense of the characteristics of this workforce, the numbers that's involved, the areas of utmost need, the areas of skill shortages, or even areas where we have surplus. And those sort of information is really crucial if we want to strike a good balance in terms of managing the supply and demand for the public health workforce. And I'm just going to wrap this up really quickly, because I don't want to repeat too much of what the earlier panelists have already said. I think that preparing the next generation of health professionals requires a good understanding of all those issues that I've mentioned. Education and training can be quite costly for taxpayers, costly for the universities, and costly for the students themselves. So having an imbalance between workforce supply and demand would lead to enormous costs, both financially and non-financially. And a study that I conducted a few years ago, which was trying to provide a little bit more understanding for myself in terms of who are the people that I teach, Masters of Public Health students and Bachelor of Health Science, what sort of careers and what sort of labor market pathways do they go into? And that study, which looked at Masters of Public Health graduates in Australia, found that more than half do not work in health-related fields, which we can interpret in many different ways. One possibility is that we have a lot of graduates actually working in areas that they did not intend to train for. But on a more positive interpretation, it could actually mean that public health training has got broad applicability and lots of different avenues for graduates to go into. So I really think that in conclusion, the main point that I can think of is the research into public health workforce development is actually very underdeveloped, and we really need to know much more so that we can start building a healthy public health workforce.
Thank you very much, Ian, and thank you to all the speakers. That was a fantastic scene setting, and there's lots of issues in there to think about. I'll hand over to Sarah now for the discussion section.
Thank you, Ingrid. Kia ora and warm Pacific greetings. Thanks to all the panellists for your wonderful insights into those workforce issues that are currently being experienced in the Pacific. We now have around about half an hour for questions. So you will see a Q&A option on your Zoom screen. A few people have already asked questions, so please plug your questions in there. There is also a chat screen where you can share your thoughts with all of the other participants or simply just the panelists as well. Now, I might actually start with a question that's just come in. So how should we determine long-term demand for the public health workforce? And this person has written to rephrase, what information should we look at to inform long-term workforce planning? And this ties in very nicely with your comments, Ian, around the challenges of actually knowing who the public health workforce is in the Pacific and where the needs are.
Yep. So perhaps I'll take the first crack at actually answering this question. I think that's a really good question. In terms of determining long-term demand for other aspects of the health workforce, typically workforce planners look at things like what is the burden of disease likely to be, and therefore what sort of clinical demand there is going to be. And in a similar fashion, determining long-term demand for the public health workforce would probably start out with looking at what we already have, which is a great unknown in many different countries and regions, and also what sort of scarcity of skills do we actually face in terms of the public health workforce, and projecting how much of those skills we actually need. For example, health promotion, what is the capacity in that area in the different countries and regions, and how much more of that are we likely to need in the future. And then looking at the current supply of the workforce and trying to see how we can actually meet that future demand.
Wonderful, thank you. Did anyone have further comments to add?
This is Vivian. I'm actually having quite a lot of difficulty hearing, and it's cutting in and out quite a bit. But is the question we're trying to address, how do we look at the workforce demand?
Long-term planning.
Okay. So here's a couple of ways of thinking about it. I think that one of the problems with workforce planning and the way it's done on sheer numbers and professional classification and qualification is it's not from the viewpoint of what do we actually need a workforce to do. And I think we actually need to think about it from the viewpoint of what's the task that needs to be accomplished, whether that's clinical care, primary care, public health, and whatever. And then thinking, so public health is obviously more difficult in terms of projecting demand because what you want to work at is prevention. But on the other hand, you can think about what are the essential public health functions which needs to be at a core. And if it's a reasonably sizable country, you might have that all to yourself. If you're a very small country, you might have to think about it in terms of how do you cooperate with other countries to get a critical mass of expertise. And so I think there's enough literature out there on essential public health functions to start to specify what are the basic things you need to do, the capabilities you need to have. Then I think you need to start to think about, if we have the problem of NCDs or climate change, then what is the nature of the workforce you actually need to be able to address this? And by what model do they actually work? And in what kind of setting? And then you work backwards on thinking about, therefore, what's the kind of mix and what's the sort of numbers And then you think about what do you have currently in place where you can actually train people and deploy people versus what's your training into the future that you need to do. Therefore, your workforce development strategy would include both the shorter term as well as the longer term. So that's just a way of thinking about how we might do the workforce planning.
Mm-hmm. Interesting thoughts. Thank you so much. Any final comments on that issue before we move along? I just wanted to quickly pick up on a point that you mentioned, Vivian, around the diversity of the workforce and the resources within the Pacific. So there's a lot of diversity amongst Pacific nations. How can we specifically support capacity building in those regions that are experiencing the greatest need?
Well, I hesitate to, answer from the distance, and I think people in the Pacific will have a much, much more granular view of the needs. On the other hand, we do know that there are some systems in place, and we do have a Pacific Open Health Learning Network where it is possible for people to get both in-service and more formal qualifications online. I think we do also have, Australia has a new Indo-Pacific Health Security Center with some emphasis on workforce development. So how does that get tapped? Because I think what's important is not just, senior people in government getting together at WHO meetings, but it's really about the frontline support that people have, and also strengthening the links between the academic institutions and the government organizations so that we can really make sure that the educational frameworks and processes are well linked into the ongoing needs of communities. So I think we probably need a number of mechanisms that that we can use to contribute to workforce development, and we need to think about that at the national level, at the sub-regional level, if you will, of the Pacific, and the broader regional level of what other resources can be brought to bear, and to think about it both in terms of on-the-job types of workforce development, as well as the longer-term education and training opportunities.
Thank you. Any further comments on this front?
Sion here, Sarah. I agree with the broad framework, the big picture that Vivian has, painted for us. In other words, for me, it's about enhancing and strengthening the emerging frameworks from the various levels of the local to the national, regional, and global, so that they are integrated, and we may maximize on the existing structures so that we lessen the repetition and the investment in areas that might not be, very useful. The other point about that, to be cognizant of the changing landscape, technology, economy, and the environment, have really changed our view of the world. We are very much a global village now, and the use of technology and the, in terms of training and development and building capacity. This is an example of us talking to each other from around the world, using technology, and we should enhance that. The other thing is the intersectorial approach in terms of developing what needs to be taught. Sustainable development area, there is a lot of research done in that area that should come in to inform the contents and the curriculum of what we teach in the education sector for the public health sector, given the interconnectedness of the global and national challenges that we face. So it's about becoming more intersectorial, using technology, enhance and strengthen the existing frameworks that are there, and make sure that we are all connected with an understanding that at the end of the day, we are moving towards a very globalized community, and the global challenges are impacting equally on the local level. But as also Vivian said, to tweak and adapt to suit our context. If you are scattered, small group of islands in the Pacific, it's about connecting up with those who have the capacity and not try to reinvent a wheel and so on and so forth. But also from the other side, what are the unique knowledge and experience of the small island states in the Pacific that can help us inform what we teach and how to address our issues? Thank you.
Thank you. Now, there are a number of questions coming through about specific qualifications, and I'd just encourage the panelists to please write a text answer to any of these questions if you have an answer on the tip of your tongue. And I'll flick through to one of those questions. Keen to hear Paula and Berlin's views on public health career pathways within Fiji and other Pacific Island medical systems for those with postgraduate qualifications interested in health promotion and research, given the workforce classification they mention with clinical doctors being labelled public health practitioners. So Paula and Berlin, perhaps you can speak to the public health career pathways in Fiji.
Yeah, well, just for 15 seconds on the last question.
Yep.
The Pacific is a region that it has similarities but many differences. 22 Pacific Island countries and territories with populations of between 1,000 and 8 million. And one of the principles that we discuss a lot in the Pacific is this notion of capacity building for the countries that are big enough to perhaps do a little bit more of their own, capacity supplementation for those that need some help, and capacity substitution for the ones that can't do it on themselves. And in saying that, I think it's fair to say that Australia and New Zealand connections has a big potential to assist in how things are done in the Pacific. If we look at clinical sections, any discipline would be able to name their counterpart college in their own discipline and will know at least a few people who come in and help from New Zealand and Australia. So I'm just bringing it up in terms of the last question so that people can perhaps have to give it some thought in how the different organizations and different individuals can provide some support. In terms of career pathway, it's a challenge to discuss this issue, because if you look at the different clinical pathways, it's very clear for clinical pathways. For public health pathway, not as clear. And there's been a number of efforts by different countries to deal with this in different ways, in developing the career pathway so that the clinical services travel along the public health pathway so that there's no issues in that, in their promotion and their career development. And so there are a few countries that have done, for example, Fiji has a relatively clear pathway, and so is the case for some of the other countries. But I suppose one of the things that a lot of Pacific doctors talk about is how can you progress as a public health physician from linkages and potentials to link to others. SPC has an MOU with the New Zealand College of Public Health Physicians. We are an accredited training institution. We've had trainees who come to spend time with us as part of their training. We've had senior public health physicians who've come and done their sabbatical with us. But looking at how perhaps we can look at opportunities to go the other way is something that we're discussing. And I'll just hand over to Berlin, because Berlin is one of the Pacific physicians who's become a fellow of a college. In his case, the UK, and just give some few pointers.
I guess your question one on public health career pathway, Paula has alluded to the pathway and some of the comments around that. Specifically on public health workforce when it comes to doctors and their specialist registration, I think being on the Fiji Medical Council myself, we sometimes define them, they struggle to define them properly. So for recently, we have registered our first occupational health specialist. And to do that, we had to go back to what is the definition and then put it under council. Then we regulate that personnel. So I guess the other challenges for the other countries is the similar. While traditional public health specialists were epidemiologists, for example, but when you go into the other fields of public health, health promotion specialists, and how do we get them to that pathway? Specialist training in terms of fellowships, it's as simple and as difficult as the colleges, the willingness to accept a specific person and to accept that they can do their fellowship requirements within the region, Australia, New Zealand, and in the countries themselves without giving up the standards. So that's the career pathway that I went through. I did a lot of competency requirements here. I spent time at Oxford and other placements as required by the college. And then I completed the assessments required. So I guess it's the willingness to, yes, engage and be flexible. They could do part of it in New Zealand, could do part of it in Australia, as long as the competency bit is not, and the standards is not given up. Thank you.
Thank you. Now we have a couple of questions about education, so I'll tie them together. So the first one, what are the attributes of an effective public health workforce? What skills should we be instilling in our students? And the second question, how do we meaningfully include Pacific perspectives, including Indigenous epistemologies and ontologies, in public health education and across public health strategies that genuinely engage Pacific communities? So a couple of really big questions there. Who would be keen to tackle these first up? Vivian, I think you.
Look, I'll have a go, and I'll draw perhaps on my past to suggest a way to go. You know, within Australia, there have been for a long time discussions about whether public health courses should be accredited. And in the end, there's been a lot of work done on competencies and competencies of practitioners, competencies of students when they graduate, and how that relates to learning outcomes. Now, I do think it's an exercise that's important to bring together both the teachers as well as the practitioners. And, you know, at the end of the day, the public health workforce is there to make a difference. And so to have some sort of a consensus about what should be taught, how it should be taught, and how it's going to actually contribute to a healthier community, I think is an important part of defining what that should be. Now, it's quite possible in the Pacific to draw on the American, the European, the Australian, and whoever else. But I think that you have to think about what is the context, what can you really do when it's inevitably a smaller workforce, when it's going to have to be a more generalist workforce, when you really need to understand the context specificity. So I would argue for both a good participatory process, but also one that does not just take Western high-income countries as a model and think about what is a workforce that's fit for purpose and how that should be integrated into the education.
Thank you. Any follow-up comments on that topic?
Siona here, Sarah. Just to follow up on what Vivian said, I agree it has to be contextualized. What are the needs of the context of the country or group of islands that you are working on? In other words, it's the attributes of an effective public health workforce is one that is effectively responsive to the evolving needs of the community that it serves. and the second part of that question is what skill set, what skill should we be instilling? Here in New Zealand, we define competencies, the three components of competencies: knowledge, skills, and attributes. So it's the knowledge of the subject and the practical skills, as well as the qualities and the principles, the ethical component of the competencies. An example of that is our New Zealand health promotion competencies. It articulates those three components: the knowledge, the skills, and the attributes. If I may, there are a few other points to say about it, but I'll let the others contribute. I'll move on to Georgie's question, Georgie Raburo question of how do we meaningfully include Pacific perspectives, including indigenous epistemologies and ontologies in public health education. There is some experience here in New Zealand, not only on Maori indigenous knowledge, but to a small but emerging degree Pacific indigenous knowledge, including in public health. The University of Auckland, Massey University, Otago University have been developing their qualifications, their overall curriculum, incorporating Pacific indigenous knowledge. So work is being done in the tertiary sector and the education sector, especially the tertiary level. In the field, with professional associations and NGOs like the Public Health Association, the Health Promotion Forum, we have developed competencies that incorporate Pacific indigenous knowledge. Although it reflects the two settings of the traditional settings, values, and knowledge from the islands brought to New Zealand by the migrant generation, it also has the component of those who were born or raised here in New Zealand. So things like values, institutions, knowledge, practices, and protocols, so on and so forth. The broader debate, of course, is to do the research on which knowledge field and to invalidate that and to frame that into the curriculum. Those three universities that I mentioned before, Massey University, Auckland University, and Otago University, have had some useful experience in doing that. There are Pacific staff, there is Pacific research on Pacific epistemologies, ontologies, and all of that, and the field of health included. And those research and also learning from the experience of the indigenous peoples of New Zealand, Maori, using their frameworks, their methodologies, and so on and so forth, and how programs are designed. And so, perhaps I can dare say this, to a small degree, some success in doing that. And it's about, we have reached a point in time in our evolution in this region and other parts of the world where we acknowledge the knowledge systems of peoples around the world, the knowledge of the West, the knowledge of the East, and now the knowledge of indigenous peoples. Indigenous knowledge and indigenous health promotion is one of the underlying themes of the World Health Promotion Conference that we co-host here next year, April next year. So another space to further explore and to debate that. But the debate here in New Zealand is ongoing. It's not easy, but it has been done, and I think it can be done. Of course, the final outcome is actually how Pacific knowledge and experience can enhance our skill set to address health needs that are no longer about diseases and medicine and all of that, but it's now the broader range of determinants of health, from culture to lifestyles, environment, and trade economy, and so on and so forth. Thank you, Sarah.
Thank you, Sione. Any final comments on that front? There are actually quite a few comments coming through with regards to public health medicine training, which I wasn't anticipating. So I'll just read out one of these questions. Paula spoke about SPC having linkages with the New Zealand College of Public Health Medicine in terms of New Zealand trainees' ability to do training stints with them in the Pacific at SPC. Is there anything in the pipeline to help develop Pacific-based trainees to help to be able to achieve an internationally recognised public health specialist qualification? Now, is this a question that somebody here feels able to answer?
Sorry, this is Berlin. I'll give it a shot, and then just to start the conversation. I guess the issue is getting international recognition. The colleges, as Paula alluded to, the relationship with the colleges, like the New Zealand Public Health Medicine training, and in the future, there's we're looking at signing an MOU with the Australasian College of Physicians, which has pediatrics and public health under it. Is looking at linking the training to the Pacific Island countries. I think there's a possibility that you can do your attachments in places like SPC, the New Zealand Health Promotion Community, and you can gain your competencies from these areas, but the recognition comes from the colleges. The difficulty is the doctors have to do the full medical registration requirement by the councils of these countries. And in a sense, if our clinical counterparts can go for 2 years and work in Christchurch or Melbourne, then I find it difficult why Australia and New Zealand can't give that same kind of requirement to the public health group. So our doctors in our specialties like surgery, in orthopedics, spend time in Australia and New Zealand. If they could give a bit of leeway for our Pacific health doctors to access the training, attachments and the competencies achieved can be at different placements within the Australasian region and within the Pacific, including SPC and I'm sure WHO.
Mm-hmm. Wonderful, thank you. Any further comments on that topic? Okay, well, the latest question to come through, how can we most effectively build and share evidence, knowledge and information about Pacific experiences related to workforce and health needs in the region? That's a great question, given that this is a unique forum. Who's keen to answer this one?
I can give it a first shot, and then others can contribute. I mean, a few years ago, as people know, the Pacific Public Health Association was set up, and we were perhaps a little bit idealistic in the sense that we wanted the secretary to be based out of a country, so it was based out of Fiji. Our experience since then has been that it has been difficult, so now we've moved the secretariat for the Pacific Public Health Association to SPC. And the idea is with the relationships that we have with SPC and other colleges, RACP, and now we're having this discussions with PHIA and others, we would potentially develop the linkages between Pacific Public Health physicians and information to others in Australia and New Zealand, and therefore build up the relationship that way and better share information.
Thank you. Any further comments on that one? Okay, now I've got a further question to ask around funding for public health. So funding is often issue-based and in the wrong places historically. Is this an ongoing problem, and how can we address it to strengthen the public health workforce in the Pacific?
Vivian?
Okay. I think one of the challenges over the last 20 years is I think in so many Pacific countries, there was very strong primary health care. But then we had the various global health initiatives with a lot of highly targeted money into vertical programs, which creates specialization, which creates new compartmentalization in the way that people work, and which really, I think there has been a decline in the strength of the primary healthcare structures, including community engagement in many instances. So I think the era of the Sustainable Development Goals and universal health coverage does help us re-look at these things. Also, in many ways, some of these vertical programs are perhaps not as well as funded as before. Now, the Pacific is always going to be, to a greater or lesser extent, depending on the country, going to be donor dependent in the sense that the economies are volatile, and the continued presence of a range of bilateral and multilateral organizations will remain important. So I think here the issue is, how does the government really take a very strong ownership and have a very strong voice in saying this is the way money needs to be, and these are the kind of problems, and these are the structures we need to have with the communities in terms of primary health care, and because that's where a lot of public health needs to happen. So I think that's part of the challenge. I mean, I can share that at the minute with this, there's going to be, a lot more money in universal health coverage in the coming years. And I am, for instance, very concerned that it's not just the vertical programs, but it's also the vertical health system building blocks wanting to do particular bits and pieces. And you have to absolutely take an integrated approach, I think, to strengthening systems. And it takes a certain strength to be able to say, you give me the money in whatever way you want to, that I spend it in whatever way I want to, that makes sense, but I will deliver on the results. And I think that's the challenge before us, because we won't get away as much as we try to from some of these approaches to financing. And indeed, so much of public health anywhere, high-income countries, low-income countries, does depend on a little crisis in order to get that investment as well. So I think being very strategic and clever about the way in which funds are used is absolutely essential.
Wonderful. Thank you for such a comprehensive answer. Now, we've only got 3 minutes left, so I'm going to turn now to ask if any of the panelists have some final, very quick thoughts on this important topic.
Just very briefly from SPC's perspective, lots of challenges in the Pacific, but lots of interest in engaging other partners who are interested in doing some work. So we'd be more than happy to take the conversation further, either with the people in the panel or others who are involved in the call, in the webinar. And we'd be happy to discuss some of the issues and perhaps address some of the issues that have been raised with some support from you guys.
Wonderful. Thank you so much. And
sorry.
Warren, I'll hand over to you.
Okay, just to thank people for participating, and it's been very interesting conversation and stimulated quite a lot of ideas about how we might progress this discussion. I think that we're a lot more confident at the moment than we would have been a year ago that we might be able to shake the money tree, and that we would have the kind of leadership political leadership that I think Vivian was referring to just a moment ago, that there does need to be some people in powerful places saying we're going to do this and give us some support to do it.
Thank you very much, Warren. And I just want to echo those thanks to all of the panelists for your really thoughtful insights. And I noticed that there was a question about what Australia can do. So there might be a few eyes on the PHAA to see what happens next in this space. Vivian, did you have a further thought?
Yeah. I just also have a thought that insofar as the World Congress for Health Promotion is going to be in New Zealand next year, and I'm looking at seeing whether, it's possible to have a side meeting of some sort to continue this conversation, because it's always helpful to have people who are face-to-face to then work out what might be some concrete things, in the same way that perhaps at the next opportunity in Australia within the PHA, and also with the New Zealand linkage, one might think about a Pacific Health Workforce Special Interest Group or something, just to, keep the conversation going and involve everyone who may not actually be able to join a webinar like this. So a couple of ideas.
Mm-hmm. Absolutely.
Sarah, can I quickly respond to what Vivian suggested? We are happy to do that. As Vivian knows, the International Union for Health Promotion and Education, workforce development is high up on its agenda, and the conference is for that purpose. So I'm happy if the panelists and other interested parties in this conversation would like to have time and space during the conference to bring this up. And I think I may not influence the Global Scientific Committee, but I'm happy to suggest, this idea, and I'm sure they'll be warm, towards that one. Paula and Colin and their team, they've got a subplenary for focusing on the Pacific, on Pacific issues, and I'm sure workforce development can be part of that. And that's another space, but it'll be good to continue this dialogue. I'm happy to further pursue this for the conference next year.
Okay, wonderful. Thank you all very much for joining us. And we do have your contact details, so we can be in touch and let you know how we'll move forward and the opportunities to be involved moving forward. Did you have anything final to add, Ingrid?
Yeah, just to again say thank you to everyone for participating. It was great. When we had the idea to put this together, I didn't know if we would get 2 people or 200 that were interested, and it was great participation today. So thank you very much to everyone. And we'll certainly be looking at what different ways we can pursue this. The PHAA is actually going tomorrow to have discussions with DFAT here. So we will see what we can do.
Okay.
Thanks to everyone.
Thank you. Thanks for facilitating this.
Yeah, thank you, everyone. Bye-bye.
Bye-bye.
Bye.
Thank you.